Good afternoon. My name is Oliver Watson. I'm an infectious disease modeler at Imperial College London, and I'm delighted to be giving today's talk providing an overview of both the pros and cons of the global rollout of COVID-19 vaccinations. When thinking about the impact of any vaccination campaign, it's most common to focus on the public health impact of any campaign. However, how we go about quantifying the public health impact is actually a very complicated question. And as such, I will start by describing the methods and approaches taken when evaluating the public health impact of any vaccination campaign. After this overview, I will move to describe the pros of the global rollout of COVID vaccinations. And these will give an overview of the current best estimates of really the morbidity and mortality associated with the global rollout of COVID-19 vaccinations. After describing these pros, I will follow by exploring the work characterizing the cons of the global rollout. These are really focused on how vaccination could have occurred more equitably across the world, and the additional lives saved and infections prevented if vaccine equity had been prioritized more heavily. And lastly, I will then conclude with a brief overview of some of the key pros and cons that are not directly linked to the immediate public health impact of the vaccination campaign, but really talk about the sort of far-reaching pros and cons. And these are really an overview of how the study and implementation of vaccine rollouts has changed during the COVID-19 vaccination campaign, and also what positive and negative effects I believe these have had on global health and vaccination campaigns more broadly. But firstly, we need to understand how we go about measuring the public health impact of any vaccination campaign. And to do that, we need a counterfactual scenario. So this is an alternate reality in which we consider a world without any vaccines in place. Really just how would the pandemic have played out differently if vaccines weren't available? This is actually a much more complicated question than it appears. There are many different types of counterfactual scenario available. For example, if we didn't have vaccines, would we have implemented lockdowns for longer? Would these lockdowns have been more strict? And would we have relied on other public health measures, such as international restrictions on movements? If we weren't going to develop a vaccine, maybe there would have been more research and development into antiviral treatments. And if transmission had occurred differently as a result of the absence of any vaccines, maybe we would have seen a different consort of variants of concern. And I really do believe that there are an infinite number of counterfactuals. And so what most modelers and most research efforts focus on is what I call the sort of simplest scenario. And that is one in which we have exactly the same pandemic. And by this, I mean the same lockdowns, the same level of transmission, the same level of mask wearing, the same international restrictions on movement. Everybody's exact behavior is exactly the same, but simply we didn't have any vaccines available. And what was this actually going to look like? So if we bring up, for example, the epidemic in the United States of America. So in the top left here, we have the daily confirmed COVID-19 deaths in the USA, and below we have the number of vaccines administered over time. So in this counterfactual, we simply remove the vaccination. So that bottom curve goes right down to zero. And so we are then focused on understanding how the deaths would look in that new scenario. Well, it should be hopefully obvious that we would expect those deaths to increase. And so we need to understand by how much. So we might end up with a scenario that now looks like this. And then from that, we can then compare that to the original scenario, i.e. what actually happened. And we can then arrive at the averted deaths. So this is the difference between these two epidemics. And we can then add that up for a country, and that gives us an estimate of what impact vaccines have had in terms of COVID-19 deaths. And how do we go about doing this? Well, we use mathematical models. We will take a model that fits to the current epidemic, so what actually happened in each country. And with that fitted model that's able to explain deaths, infections, seroprevalence, etc., we are able to then estimate the reproductive number over time, also known as RT. And this is the mean number of secondary infections in the absence of infection-induced and vaccine-derived immunity. And this is a very key point, because what it really means is it's just describing how individuals have mixed and allowed infection to potentially spread. Once we have estimated RT, we can then simulate an epidemic without those vaccines. And so, for example, this is what that would look like then for the USA in a study that we led that came out earlier in the year. And so in black again is what actually happened, and in red is what would happen without vaccines. And the difference in blue is the impact that vaccines have had in terms of the number of lives saved. And what's really helpful about this kind of counterfactual approach is we can then look at different possible scenarios once we have that estimate of RT. For example, we could say, what if vaccines only provided direct protection? So this is the reduction in risk of death conferred to you as a result of taking a vaccine. We can then take away from that what impact it also had in terms of reducing onward infections. And this is a really helpful policy message and very key in helping convey the benefits and pros of a vaccine campaign. So now we've covered the primer on how we go about estimating the public health impact. I will give an overview of the pros of the global rollouts, and these are focused on the public health message again. So firstly, the number of lives saved as a result of COVID-19 vaccines. In that same study, we estimated that almost 20 million deaths were prevented worldwide during the first year of COVID-19 vaccination. And importantly, almost 7.5 million deaths were prevented in countries that are covered by what is known as the COVID-19 Vaccine Access Initiative, COVAX. And this was an international agreement to ensure that individuals had access to COVID vaccines regardless of their wealth and where they appeared in the world. And so these are individuals really in lower income countries. And so this is a clear benefit and real success story of the COVID-19 vaccine program, that we were able to ensure a large number of deaths to be prevented in countries that may not have had access to vaccines otherwise. And what we can see here is that while the initial number of deaths averted here, shown in this sort of green curve in the right plot, peaked in the middle of May 2021, this is due to the large epidemic in India. This was then followed by deaths being averted in higher income countries who were able to ensure high vaccine coverage before relaxing their interventions during 2021. We can next move to the number of infections prevented. Using that same scenario, we estimate that 1.5 billion infections were averted during the first year of COVID-19 vaccinations. And so depending on your case definition for long COVID, this could be anywhere between, say, 1% and 20% of infections. We would then estimate that between 15 million and 300 million cases of long COVID were potentially prevented due to the global vaccination campaign. And then lastly, as a result of the vaccination campaign, we were able to relax public health and safety measures. So on the right here, I'm showing the level of government interventions that were in place on the 8th of December 2020. This is the day of the first COVID-19 vaccine out of any trial. And the darker colors here show stronger government interventions. As most of the world was able to start vaccinating, we see these interventions reduce across the world. So these lower blue colors across the world, with notable exceptions really in China, where they are still pursuing high levels of non-pharmaceutical interventions. And we also can see that as a result of this reduction, there have been returns to normal estimated GDP growth, here shown by the International Monetary Fund. And while these might not seem as initially as public health impacts, what this has enabled is a return to attention to other areas of public health that were potentially overlooked during the pandemic. And so we need to really focus again our attention now on how the vaccine campaign has enabled us to continue progress towards other public health impacts. I will now talk about the cons of the global rollout of COVID-19 vaccines. And these really focus on how we could have done better given the amazing tools, the vaccines that we had. So I already mentioned the COVAX initiative, but the WHO also set vaccine targets for the end of 2021. They set targets of ensuring that 40% of each country was fully vaccinated by the end of 2021. This, I believe, was a very achievable target, and it's one that we looked at in that same study. And we estimate that if these had been met, 1 in 5 of the lives lost due to COVID-19 in low-income countries could have been prevented. That's a staggering number of lives that could have been saved if vaccine targets, achievable vaccine targets, were met. And if we look at this graphically, we can see here in this plot where we're showing the number of deaths averted per population against the number of vaccines given in a population, that the majority of the greatest impact of vaccines is concentrated in this top right corner. And this is really those countries, mostly high income countries, that were able to achieve high vaccine coverage very early in the pandemic, also with highly efficacious mRNA vaccines, which meant that when they were able to relax their interventions during 2021, they were able to see the greatest impact from their vaccines. However, countries that were not able to achieve those high coverage levels early or were using less effective vaccines, generally lower income countries, saw less of an impact from their vaccine campaign. And this really is a con, in my opinion, of the global rollout, because we should have hit these targets. Next is talking really about vaccine equity in terms of hoarding and sharing of vaccines. So in our study, we really looked at whether those targets were to be hit. So this focused on increasing vaccine rollout. Whereas another way to look at this is to say, what if vaccines were shared more equally? So no new vaccines in terms of how they were given in total across the world, but just whether they were redistributed. And a group at Warwick University looked at this and found that more than 1 million lives could have been saved in low-income countries if vaccines had been shared more equitably. And again, to show what this looks like graphically, if this is the vaccine coverage at the end of 2021 across the world, again, we're seeing low coverage in low-income countries. What they looked at in their counterfactual was if we increase sharing, so we're redistributing vaccines so they're more equally distributed across the world, what does that then mean in terms of the reduction in deaths relative to the actual vaccine rollout that happened? So in this last plot here, where you see countries with a blue color, this shows a reduction in deaths to what actually happened. And what we can see here is that we could have used a more equitable sharing without really any increase in deaths across many of the higher income countries that would have to donate and share their vaccines more equitably. And so this again is another con of the rollout, that we should have really prioritized vaccine equity earlier. And lastly, I think it's important to talk about how the role that potentially vaccines had in slowing transmission and what that means in terms of variants of concern. I'm showing here on the right the level of vaccine coverage again by the end of 2021 or December 9th, 2021. And what we can see here is that there's very low coverage again in low income settings, but particularly in Africa. And wherever transmission is allowed to occur, and this will happen when there is low vaccine coverage, there is an increased chance of new variants of concern arising. It's impossible to know exactly how that landscape would have looked if vaccine coverage was improved. But what we definitely know is that where there are no vaccines or low vaccine coverage and transmission is allowed to occur, more mutations are likely to arise, and this increases the chances of new variants of concern arising, which potentially erode the protection afforded by previous infection or vaccine campaigns. And to conclude, I'm going to talk about the far-reaching pros and cons, as I've called them. And these are the sort of non-immediate public health impacts. So the first one is that as a result of the general success of the vaccine campaign, and it has been an unmitigated success, really, in terms of the lives saved and how quickly we're able to develop such effective vaccines, there are now renewed calls and interest for developing vaccines quicker. So the Coalition for Epidemic Preparedness Innovations, or CEPI, have now set this 100-day target for being able to develop a vaccine. And that will have huge impact if that can be achieved. And it's, I believe, again, an achievable goal. Secondly, there's been increased focus into understanding how vaccine uptake and hesitancy are tracked. These are really key parameters when we're trying to understand the impact that any vaccine campaign may have. And it's encouraging to see that this is increasingly a focus in terms of how we track it and also how we can increase vaccine hesitancy. Sorry, not increase vaccine hesitancy, but decrease vaccine hesitancy and increase vaccine confidence. Thirdly, one of the negative impacts related to vaccine confidence is that as a result of the wide rollout of vaccines, we have definitely seen an increased polarization of the debate surrounding vaccines. And so more research is really needed on the key flashpoints in this discussion. One really being, did we need vaccine mandates to increase vaccine uptake? And also, what role did childhood vaccine campaigns have on transmission, and how did this shape public appearance and vaccine hesitancy. And lastly, what we've seen most recently is that as a result of the success of the COVID vaccine, there is interest in developing other vaccines for other diseases. We had the first malaria vaccine, for example, approved in 2021 after 30 years of development. And we're already seeing promising signs of a new vaccine with trials in 2022 showing very high effectiveness in preventing disease in young children. And so to conclude, we've talked about how we measure the public health impact and the pros that the rollout has had in terms of the lives saved and infections reduced. We've talked about the cons, so really how vaccine inequity led to a preventable loss of life. And it was concluded really looking at the secondary and far-reaching impacts about how the success of the vaccine rollout has hopefully led to a new landscape in which we are able to produce vaccines quicker and better able to ensure high vaccine coverage and address concerns around vaccine hesitancy. And these will hopefully trickle down into improving vaccine development for other diseases. Thank you for your time.